Today's webinar on perfusion imaging and advanced biomarkers in acute stroke care. This session is intended for experienced clinicians and will focus on practical interpretation, advanced imaging biomarkers, and case-based decision-making across a range of real-world clinical settings. My name is Carolina Meyer, and I'll be moderating today's session. Just some webinar format and housekeeping items. Today's session is delivered via the Zoom webinar, so attendees are in a listen-only mode with microphones and cameras disabled. We'll begin with focused presentations from each speaker, as well as some case-based discussions, and then we will have the live Q&A. The session is being recorded and will be shared following the webinar with everybody. Please submit your questions at any time using the Q&A function at the bottom of your Zoom screen. I'll be monitoring all the questions that come in and will direct the questions to the panel during the discussion segment. The chat is also available for general comments. We're pleased to be joined today by three international recognized experts. Dr. Greg Albers is professor of neurology at Stanford University, the director of the Stanford Stroke Center, and the scientific lead and co-founder of RapidAI. Dr. Albers will be discussing how to interpret perfusion imaging in clinical practice, including interpretation of perfusion maps, assessing the quality of CT perfusion, and then common misconceptions and pitfalls that are associated with that. Dr. Albers will also lead some case-based review and discussions. Professor Pierre Senners is a neurologist at the Adolphe the Rothschild Foundation Hospital in Paris, France, and the neuroscience research at the Institute of Psychiatry and Neuroscience in Paris. Professor Senners will discuss the application of advanced perfusion biomarkers, focusing on the use of HIR and CBV indexes to predict collateral status. He'll also discuss how to anticipate infarct growth, particularly in patients undergoing transfers, as well as the role of imaging biomarkers in predicting clinical outcomes. Also with us, Professor Mario Sikojos, who is the head of Diagnostic and Interventional Neuroradiology, co-director of the Stroke Center, and a member of the management board in the Department of Clinical Research at the University Hospital of Basel, Switzerland. Professor Sikojos will conclude the presentation segment with a discussion on the role of perfusion imaging in the medium vessel occlusion, the MEVO detection and selection, including perfusion status, CTA for MEVO detection, perfusion versus CTA, the role of perfusion imaging in selecting MEVO patients for thrombectomy. Just also some disclosures and educational framing here. Today's discussion reflects the clinical experience and the academic perspectives of the speakers and is intended for educational purposes. With that, I'm pleased to hand it over to Dr. Greg Albers to begin today's first presentation. Thank you.
Thank you. Very ambitious agenda over the next hour, so we better just dive right in. I will be focusing on interpretation of perfusion imaging, and we're going to start off with a case. So here's a 79-year-old woman. She's got a past history of atrial fibrillation. She's functionally very independent, working 30 hours a week, takes care of her daughter, who is disabled. She presents with really a horrible clinical syndrome, left gaze deviation, right upper and lower extremity flaccid hemiplegia, nonverbal, not following commands, very high NIH score. You can see from the CTA that she's missing her carotid and MCA on the left. But the non-con CT does not look too bad. You can see that there's minimal hypodensity in the left hemisphere. This is a very early scan because she got in very quickly after symptom onset. And of course, everybody would be thinking, let's immediately do a thrombectomy on this case. The perfusion imaging might give you some pause when you take a look and you see that she has estimated core. Here's a lower and upper slab. Adding together is getting close to 300 mLs. And then if we look at the severity of the perfusion deficit, you can see that even for CBF less than 20%, which means regions that have more than an 80% reduction in CBF, we're still looking at over 225 mLs worth of core. Let me just put on the laser pointer here so we can show you some things. So you're going to be hearing quite a bit from both Pierre and Marios about collateral measures of severity. So one of them is the HIR, and an HIR of 0.9 means that there is very poor collaterals, and that is complemented by the CBV index, which means that the blood volume in this patient's left hemisphere is also extremely low. If we look at the standard image columns off CT perfusion, the dark blue areas here mean that there's essentially no blood volume and no blood flow into the left hemisphere, making this practically a cardiac arrest of the patient's left hemisphere. So despite the fact we didn't see much on the non-con CT, this is a patient who has virtually no collateral flow and no blood flow into the left hemisphere. But the patient was coming in very early. They were transferred to Stanford and immediately went to the cath lab where TICI-2C was obtained in 2 passes. And all this was done within 3 hours or so of symptom onset. A few hours later, the patient had less reactive pupils. A CT was obtained, and you could see there was very early herniation. And the patient didn't make it more than a couple more hours. So this is an example of how there can be a big difference between what you see on perfusion imaging and what you see on a non-con CT in an early window case. So what's the value of perfusion imaging in triage? Well, Marius is going to talk a lot about MEVOs. For example, this patient that you see on the upper right, you might immediately notice that there's an M2 occlusion because you're good at reading CTAs, but if you're not, anybody would notice that you have an anterior division M2 occlusion once you get the perfusion imaging. We also know that from various clinical trials that virtually all the positive late window studies used perfusion for selected, and there have been dozens of trials that didn't and have not had success. So my focus is going to be how do we interpret these images, and we're going to start out with how do you do a CTP, and what you do obviously is rapidly inject through a power injector a contrast agent, and then you're going to follow that path through the brain. So you're going to identify when that contrast bolus goes through an artery at the base of the brain, and that's going to be called the arterial input function. This is going to be the most early arrival into an artery, nice upslope, nice peak. This is called the AIF. Then that contrast bolus is going to leave the brain through a venous sinus, and you're going to see that with a higher amplitude as it leaves a large venous sinus. Obviously, the venous output will be delayed a few seconds from the arterial input. What you want to see is 2 vertical dotted lines, which are going to tell you that how much time did we identify as the normal 0 baseline before that contrast arrived. If you only see 1, it means the contrast arrived before you started the scan, and that's not going to be good. If the lines are very far apart, it means that you radiated the patient for a long time before the contrast arrived. So you want to see just a couple of seconds of the baseline, and that means the 2 dotted lines. So here is an example of finding out where the AIF was selected. So for every perfusion imaging, you'll see a red dot over the spot the AIF was picked. This is usually going to be the middle cerebral artery, contralateral to an occlusion. And then you'll see which venous sinus was selected in blue for the exit of the blood from the brain. From those maps, you're going to be able to generate the cerebral blood volume, the cerebral blood flow, which is heavily based on the upslope of the AIF, time to peak, mean transit time. So a variety of perfusion parameters can be then displayed. But it has to be technically adequate for them to be meaningful. So here's an example of a bad CT perfusion scan. So the first thing you see is that the distance between the 2 vertical dotted lines is nearly 15 seconds. That means you radiated this patient for a long period of time before the contrast bolus arrived. So there was poor timing. And because of that, we are truncating the venous outflow, and we're even truncating a little bit of the arterial input. The other thing that we can see is that this patient was moving like crazy during the scan with both rotational and translational movement, which is going to mean a poorer quality scan. So we have poor bolus timing and we have a lot of movement, which means that we're going to not get good quality information out of the CTP. So the patients have to be held tightly in the scanner. They need to be holding still at the time of the scan, and the bolus needs to be timed perfectly. So here's a perfectly timed bolus. Here's a beautiful AIF and VOF and a patient who's not moving. So you always want to look at the input data before you analyze the scan. Once you get the scan and you have good input data, you typically look first at the mismatch map. But this is just an introduction to what's going on with the scan. On the mismatch map, we're going to have an area where we look at the delay in the arrival of contrast. And here we dichotomize at 6 seconds because PET scan data and Xenon CBF data have shown that if there's more than a 6-second delay, this tissue is likely penumbral. It's within the penumbral threshold of 20 ml per 100 gram per minute of cerebral blood flow. So this is giving you an idea of how much tissue is at risk. And then on the other side, you're going to look at the area that has a substantial reduction in CBF. The standard is a less than 30% CBF compared to the normal patient CBF to identify tissue that's likely irreversibly injured. So how do we get this? Well, you start with the Tmax map and you look at all the tissue where the Tmax has normal arrival and you calculate the CBF from those normal regions, both ipsilateral and contralateral to the stroke. Then you know the patient's normal CBF, and then you can apply these thresholds and say, show me a 70% reduction in the patient's normal CBF, and that will be identified in this magenta color. And in this case, you can see it's a very small volume compared to a very large volume of tissue that has critical hypoperfusion. So a lot of salvageable tissue in this patient. All right, what if you get a map that doesn't show you any magenta or any green? Well, there is still a tremendous amount of information here because these are grayscale maps of both Tmax and CBF. So the grayscale on Tmax means that if the Tmax is delayed, it will be bright. And how do you know that? By looking at the ventricles where their blood flow never arrives, it's bright white. So here's bright white ventricles. Tissue that is white but is not 6-second delayed means that there's a delay, but it's not critically hypoperfused. So if I look at this patient's right hemisphere, I can see that the right hemisphere has a bright area, and this is compatible with carotid occlusion, which is what this patient has. So the carotid occlusion is chronic in this case, and it is giving you this mild delay into the right hemisphere. We also see some regions where it is bright white in the right frontal lobe, same as the ventricle. So this is telling you blood flow is never arriving. So this is an area of encephalomalacia for the old stroke that occurred when this patient had the right ICA occlusion. You also see what looks like somebody took a marker and put a white line across the front of the brain. And that, when you see that, it tells you the patient has been moving. You can see that marker in the back here. So I'm learning a lot about this patient. One is they were moving during the scan. 2 is I've got delay in the right hemisphere. And I've also got an area of old infarct here because I see no blood flow attaching to this ventricle. Now, if we move on to the CBF map, this is also a grayscale map where we can figure out easily what color is low CBF by looking at the ventricle. So here it's the opposite of Tmax. Rather than a white ventricle, we have a black ventricle. And that means that black means no CBF. So if I look into that same area that looked like there was encephalomalacia for the Tmax, it is pure black, just as black as a ventricle, no CBF whatsoever. So this is an area of old encephalomalacia. If I saw other areas that were dark but not black, that could be CBF that's reduced but not low enough to meet this threshold of less than 30% of normal. But what I see in the right hemisphere, which is a hemisphere we know that had a previous stroke, is I'm seeing bright CBF hugging the cortex. So bright CBF means high. So this is a patient where in a cortical distribution we have very high CBF. So this is a patient who is having an active seizure involving that right hemisphere. So you can see even in a mismatch map with no green and no magenta, we can get a lot out of looking carefully at the grayscale maps. Okay, So let's now go beyond the mismatch map. It's very important to look at the other images. The next map you'll get will be a 4-threshold Tmax map. So we're going to be able to see in blue areas of benign oligemia, mild delay that are unlikely to be critically hypoperfused. And we're going to see in red areas of severe delay in the arrival of the contrast, more than 10 seconds delayed. So how you get this is you look at when the tissue contrast bolus gets to the AIF, which is a normal vessel, and then how many seconds delay to get to the brain tissue. More than 10 seconds by definition means poor collaterals. So here we've got a large region of very severe delay, meaning poor collaterals to the left hemisphere, similar to the case that I just showed you. And Pierre will show you how you can use these delays to come up with the HIR, which is going to give you a quantitative estimate of collaterals. Probably the most important map in all of the CTP are the image columns. Here you've co-registered the non-con CT with the cerebral blood volume, cerebral blood flow, mean transit time, and Tmax. And you can look individually to see regions of high or low volume or flow, delayed mean transit time. The mean transit time can be particularly helpful. This is the capillary transit time. And in somebody with an acute stroke, the capillary transit time delay will mimic the pattern that you see on the Tmax. So this is an acute occlusion of the left MCA, and we're going to see that the mean transit time is delayed in the same regions where the Tmax is delayed. If the mean transit time was normal, it would tell me that this was a chronic occlusion. So you can help differentiate acute from chronic by the mean transit time map. Okay, let's talk about some limitations of CTP. Unfortunately, most of us, when we went to medical school or residency, we did not have a course on how to interpret CTP, and it's really important to understand the limitations. The most important limitation is that CTP reflects the hemodynamics at the moment the scan is done. It does not give you historical information about what happened yesterday or what happened 8 hours ago. So here's an example to demonstrate that. This is a patient who's scanned at 2, 4, and 24 hours. And on the y-axis is the reduction in CBF. So this dotted line is a magic 70% reduction. That's the reduction that will trigger the magenta color on the map. So here at 2 hours, this patient comes in. We don't see anything on the non-con CT. We can see from the Tmax that this is clearly an MCA occlusion because it's the MCA Tmax distribution, and that at that time, the part of the brain that has a severe reduction in blood flow is going to be the deep watershed area. So we've got a small estimated core, we've got large region of penumbra. Then what happens? The patient zips off to the cath lab, and somebody like Mario pulls the clot out, and immediately you get a huge rise in CBF. You've got dilated vessels because you're trying to vasodilate to bring as much blood flow to the penumbral region. When you reperfuse that, you're going to get hyperemia. You get high CBF. If you were to do a scan right here, you would see the CBF was actually high. Again, it would be bright on that map that is grayscale. And then it's going to come down. By 24 hours, what we can see is the CBF is coming down to normal, but it's coming down to normal in virtually the entire left hemisphere, even the area where there's an obvious infarct. The reason for that is because the blood vessels are still intact in the area of the infarct. So after reperfusion, the core disappears on CTP, and it's going to appear on non-con CT. So non-con CT is going to show you the core, where CBF will not show you it in the later time windows. In the early window, CT perfusion shows you the core, and non-con CT doesn't. If you look at the Tmax, it's a little bit darker on the grayscale. Darker means early arrival. Again, we're still vasodilated a bit, so we're seeing early arrival of the contrast in the reperfused hemisphere. All right, here's a patient that is a little more complicated because they did not have recanalization. They're imaged at 2, 8, and 24 hours. At 2 hours, they looked identical to the last patient. We have an MCA occlusion. We've got a small core, a normal non-con CT. By 8 hours, collaterals are starting to fail. The Tmax lesion is getting bigger because some of those cortical collaterals are not doing as well. And because of that, this deep area of hypoperfusion is getting more severe. So we now see a larger volume with a severe reduction in cerebral blood flow. The pink area is getting bigger, and it's starting to get closer to matching what we see on the non-con CT. Eventually, if you kept scanning this patient, you'd get to a point where the pink area and the green area are at the same size, and we say that's a matched deficit. Basically, the stroke has come to completion, no more salvageable tissue. It's not that common that you're scanning right at that time period. It's more common that you'll scan later after some of the collaterals have tried to kick in. So here at 24 hours, what has happened is those ACA and PCA collaterals are providing more cerebral blood flow to that ischemic area. And that's why the CBF doesn't look so low along the cortex. It looks very, very low here in the infarcted area because this is a patient who's gone on to have a very substantial infarction. So why has the pink disappeared here? The CBF is very low. The reason for that is because if you have very low Hounsfield units, if you're very dark, then the CBF pink area will be suppressed. And the reason for that is you don't want to see old infarcts turning up as magenta, because if this patient had old infarcts in the right hemisphere, you don't want to get confused by that. So the magenta means it's a new area of low CBF that is not matched by very low Hounsfield units. The reason you don't see low CBF out to the cortex is because the collaterals have raised the CBF. So even though there's still an occlusion, the CBF is not as low as it could be earlier on. So there's two reasons why this pink core can disappear over time. Again, making the point that you're going to get a lot more information about core off a non-con CT when you get into the later time window. The Tmax is going to tell you that the patient did not reperfuse. Okay, some more limitations of CTP. Clinically important perfusion delays may be less than 6 seconds, so it's very important to look beyond the mismatch map. Here's an example. This is an older scanner from one of our referral hospitals, and they looked at this mismatch map and they said, looks normal to me. But if you look closer, I think you'll see that it's not normal. This was a 52-year-old who presented with stuttering right arm weakness and intermittent aphasia. At the time of the scan, the neuroexam was normal. And if you look at the scan, if you look at the Tmax map, I think you could be convinced that there's a little bit brighter signal in the left hemisphere, particularly in the watershed areas. In the frontal and the more posterior area, it looks a little bit brighter. And if you look at the CBF map, I see a darker region here in this watershed between MCA and PCA. What this is telling me is that there's some reduced blood flow, but it's not reduced by more than 70%. And there's some delayed blood flow here, but it's not delayed by more than 6 seconds. If you look at the 4 threshold Tmax map, I think it's easier to see that we've got a watershed territory, and it's even easier to see that when you look at the color map, right? I can see a watershed perfusion deficit going on in the left hemisphere. So this is not a normal map. This is flagging us to see that the carotid distribution on the left has got delayed flow. We can see that there's some increased CBV. The vessels are dilated, trying to bring as much blood flow as possible to that left hemisphere that has a carotid stenosis that turned out to be very high grade, and the next day went on to an occlusion. The patient had a large watershed infarct, and the referring site said, hey, why was there a normal CTP in somebody who had a high grade left carotid stenosis? And the answer was it was not normal. You just need to look more carefully than just flipping through a mismatch map and saying those no colors. I'm going to finish up by talking about how to avoid overestimation of core or penumbra. People will often talk about ghost core, meaning that there's area that's positive as being estimated core on the CTP map, that it doesn't go on to infarct. And this occurs almost entirely in patients who come in early, very early, with what we call the golden hour, which we generously define as 90 minutes after symptom onset. If you're within 90 minutes, a CBF reduction of 70% is not necessarily enough to cause irreversible injury, but what we find is as you go to an 80% reduction, in other words, the CBF is less than 20% of normal, that tissue is almost always irreversibly injured, even in the early setting. In the SELECT-1 trial, we found that although you would see some ghost core in early patients, particularly if they had early and complete reperfusion, that the ghost core completely disappears if you use the 20% threshold rather than the 30% in patients who present within 90 minutes of the scan. So in the patient I showed you who was scanned within 90 minutes, we were looking at the 20% threshold to estimate the core rather than the 30%. So that will take care of the ghost core issue. And then finally, I just want to mention, finish with this case showing, again, chronic occlusion versus an acute occlusion. So here in the acute occlusion, you have a larger Tmax delay, more severe, more red. The MTT matches the Tmax, low CBV, low CBF, where in the chronic occlusion, you still have Tmax. So somebody with moya, somebody with a chronic occlusion, you still may have 6-second Tmax delay because this is just showing the delay. But if you've compensated because it's chronic, the MTT will normalize. So this will help you. The CBV and CBF is typically normal, and the chronic occlusions are maybe a little bit increased because of that vasodilatation. So that was a whirlwind tour of how to interpret CTP maps. And I'm going to now turn this back to Carolina.
Thank you so much. Amazing class here on CT perfusion. Thank you so much, Dr. Albers. So now we're going to move on to Dr. Pierre Senners, and we're going to learn about the collaterals that you mentioned during your presentation, Greg. Pierre, please go ahead.
Unmute, Pierre.
Sorry. Thank you, Karina. Good morning to everyone. Let me share my screen. Okay. So thanks for the Rapid team for inviting me today. So I'm Pierre Senners, working in a stroke center in Paris, in France, and I will speak about the predictive power of biomarkers and more specifically about how perfusion imaging may help us to estimate infarct core growth in patients that need to be transferred from a primary to a comprehensive stroke center for endovascular therapy. So you probably all know that interhospital transfer for thrombectomy is a very common situation. You have here the maps of the stroke centers in France on the left and the USA on the right, and in both countries, and it is the same in most countries worldwide. Most stroke centers are not EVT capable. And therefore, most large vessel occlusion patients are first admitted in primary stroke center or non-EVT capable centers where the LVO is diagnosed, and then the patient needs to be transferred to a comprehensive center to get the thrombectomy. And roughly, we estimate that more than half of the thrombectomy procedure are performed after an interhospital transfer. So this is really a very frequent situation. And we also all know that transferring this patient is complex and it's time consuming. We have here data from the French thrombectomy registry, over several thousand of patients that were transferred from a primary hospital. Indicating that the median transfer time, so from the first imaging in the primary stroke center to the ground puncture in the comprehensive center, the median time was over 2.5 hours. And so it may be that French people are slow, but in fact, when you look at all the publication in every country, it's the same amount of time. So it's always very a long transfer. And the longer the transfer time is, of course, the lower the probability of reaching a good 3-month functional outcome. And this is, of course, because as time elapses, the infarct core will grow and the ischemic penumbra, so the tissues that can be salvaged, will decline. But we also know that there is massive heterogeneity across patients in terms of infarct core growth. And I will show you this with those two cases. So it's two patients with a large vessel occlusion of the anterior circulation with a high NA stroke scale score who were admitted in primary stroke center, and they get here an MRI. You have the patient on the left, the case number 1, showing a deep MCA infarct with a core rating of 10 cc. On the right, case number 2, pretty similar imaging with a small ischemic core in the deep right MCA territory. The core is 5 cc. So those patients were transferred then to a comprehensive stroke center. They both arrived 3 hours later. But you can see that the evolution of the core was very different in those 2 cases. The case number 1 has a massive core growth over those 3 hours, despite showing a very stable intracranial occlusion. The core went from 10 cc to 77, while the case on number 2 on the right had minimal core change from 5 to 7 cc, and again the occlusion site was very similar in the 2 MRI. Though on the left we have what we call a fast progressor, on the right a slow progressor, and now the big question is how can we differentiate these 2 cases? In fact, when you look at the perfusion maps that was performed in the primary stroke center, you see very different maps. The patient number 1 had very severe hypoperfusion with a HIR of 0.81, while case on the right, number 2, had very low HIR 0.16. So what is the HIR? As Greg already mentioned, is the ratio of the Tmax greater than 10-second volume over the Tmax over than 6-second volume. It has been constantly shown in several publications as strongly correlated with leptomeningeal collateral status, as evaluated on DSA. You have basically 2 different profiles: the patient with poor collateral, HIR over 0.4 or 0.5, depending on which cutoff we use. Those patients have a lot of Tmax greater than 10-second lesion, a lot of red on the imaging on the left, while patients with good collateral, so low HIR, the patient on the right have a very limited amount of Tmax greater than 10-second lesion, so very little red on the map. So it has been shown that the higher the HIR, the higher the interhospital core growth. We have shown that in a cohort of patients with 2 MRI, the first one in the primary stroke center, the second one when the patient arrived in the comprehensive center with a stable occlusion, and patient with high HIR had, so poor collaterals had large infarct core growth, while the patient with low HIR had almost no growth. When you dichotomize this HIR, the best cutoff was 0.4 in this study. Patient with high HIR, poor collaterals, and very frequently were fast progressors was a patient with low HIR, good collaterals, had minimal core growth. So now you can tell me, okay, these are MRI data, but I mean, we all use CT, which is true. But what is very nice with this biomarker is that we have extremely consistent results on CT and MRI. And this has been shown in this study where we had a large cohort of patients with CTP, another one with MRI, and you can see that the results were exactly the same in the 2 cohorts. So the higher the HIR, the higher the rate of fast progression. So this tool can really be used regardless of the imaging modality. Let me show you those 2 additional cases on CT. Again, those patients were admitted in primary stroke centers very early on, M1 occlusion, high aspects on non-con CT, 9 or 10, very high NIH stroke scale score, very favorable profile on CTP, very small core on both cases, less than 10 cc, very large Tmax greater than 6-second lesion. So a lot of mismatch in both these cases. Those patients were transferred to comprehensive center where they arrived a few hours later, and the patient on the right again has a large core growth from 8 to 51 cc's, and the one on the left, on the right, sorry, had no growth at all. So again, fast progressor on the left, slow progressor on the right. What difference? So these 2 cases, it's their HIR, which was very high. In the case number 3, a lot of red, Tmax greater than 10 seconds high, HIR 0.6, while on the right, the patient has a low HIR, very favorable collateral on the assay. So we can also use the CBV index, which is another biomarker of collateral status, which has also been shown in several publications. So what it is the ratio of the mean cerebral blood volume within the Tmax 6 lesion compared to the mean CBV in the normally perfused brain tissue And it has also been shown as strongly associated with interhospital core growth. So basically the patient with high CBV index with the optimal cutoff being used is 0.85. Those patients have minimal core growth over time, while the patient with low CBV index have large core growth over time. So again, two different patients with very similar profile, small ischemic core on CBF less than 30%, high Tmax lesions. But you can see if you look at the CBV index, which is provided by Rapid, that they are very different in those two cases. The one on the left have a low CBV index, indicated poor collateral, while the right on the right has high CBV index, indicated very good collateral status. So the patient on the left is a fast progressor and the one on the right is a slow progressor. So, but why is it important to be able to identify if the patient will or will not be a fast progressor? Because of course it's strongly correlated with the poor 3-month functional outcome. And it has been shown in several publications. I show here the two main ones in inter-hospital transfer patient. The patient with slow progression have overall good functional outcome, while the patient with fast progression have poor functional outcome. Another way to show that here on this slide, it's how the probability of reaching a good 3-month functional outcome, depending on the time from onset to reperfusion with EVT. So these are only patients with successful thrombectomy, TK2B3. You can see as time elapses, the probability of good outcome is lower for all patients, but that time is much more critical for fast progressor patients. So this is very useful information to know before transferring a patient, because this can be help for some decisions whether transfer is advisable or not, and also, of course, to inform the family about the expected outcome of one patient. It's also very useful for future research. You all know that neuroprotection trials are now started. And we do not want to include the slow progressor patient in this type of trial because very limited core growth will occur over several hours. And it's unlikely to be able to show any benefit of a neuroprotective therapy in this type of population because basically nothing occurs in several hours. While the fast progressor is the optimal target population for such a clinical trial because a lot of things will happen in terms of core growth. And if we have an efficient therapy, an efficient neuroprotectant treatment, there we can find a potential effect in this type of population. So we really want to include only this type of population. And the tools that I have shown can be used to enroll the good patient to have positive trials in the end. So here are my take-home messages. First, infarct core growth during transfer for thrombectomy is highly variable. The rapid core growth during the transfer strongly predicts the clinical outcome of our patients. And we have the perfusion-derived collateral biomarker, the HIR, the CBV index. We are the primary marker that can help to determine the core growth of our patient. So this has clinical relevance. It can help to improve patient triage decision, whether or not we should transfer a patient. It can help also to inform the relative about the expected outcome and last support the selection of patient in our neuroprotection trial. Thank you very much for your attention.
Thank you so much, Dr. Senners. A great presentation. I think we're all learning a lot here. As Dr. Albert said, it's a very ambitious webinar, but we are all learning a phenomenal amount of information. So now we're going to go to Dr. Sikojos, and we're going to learn a little bit more about MIVOS and some information about the trials that he's been highly involved in, as well as how to handle these patients in clinical practice. Dr. Sikojos, please go ahead.
Thank you, Carolina and Amanda, for this invitation. It has been a fantastic webinar until now, and I hope I keep up to the quality of the other two speakers. So we're going to talk about MDVO stroke, medium or distal vessel occlusion, as I usually try to refer to MIVOS, as you know them, or DVOs. We're going to talk about MDVO detection, about the prognostic value of perfusion, about using perfusion as a potential biomarker, and then end with my topic that I really love, one-stop in stroke, and how perfusion can actually help us there. So I've been talking about those maps for a lot of years, right? You have seen those. If you haven't, I can prove it with some social media posts that I have posted in the past. And I've always told, for us here in Basel, perfusion is our MIVO detector. And we use it 24/7. We always do perfusion for our patients. And I think that was one of the reasons why we were detecting so many MIVOs during the distal trial and then also randomizing the patients. So there have been studies showing that this is crucial if you see what's the reason of missing vessel occlusions. One of them is distal location, right? And then if you see this other paper, you can see that distal occlusions have a really low sensitivity, or physicians have a low sensitivity if they're trying to detect distal occlusions with just CTA. If you add CTP on this, it gets much higher. And these are data that we have just submitted to a journal where you can see our own study on this. We call this a distal detection trial. And we try to have a little bit more sophisticated analysis of the physicians and the results. So you can see here, for example, a first-year resident has a lower sensitivity as an interventional neuroradiologist or a stroke neurologist. But across all the spectrum of physician grades and specialties, you can see that there is a jump if you add perfusion to the mix. I will show you this also in some examples later. We try to do this trial also with some timing that's restrictive in the emergency setting. So we try to replicate what you usually will have as a first-year resident in the night, where you have your physicians, your neurologist that want an answer within 2 minutes. And again, I think this is really, really important to consider that you don't have the whole time of the world in the night to analyze the CTA and find the occlusion. You need the perfusion to actually be able to find this. So this was primary detection that we talked until now. What about MDVO detection after thrombectomy, right? These are some slides that we are also going to discuss later about a product that is now available in the angio. So you can now do perfusion on Siemens machines with the flat panel CT, and then you can analyze it with Rapid, and you can get perfusion maps. And those are all TK3 examples, where actually you can see that there might be also some residual occlusion left. And then in those cases, you go on and treat additionally with some intra-arterial lytics, for example. Right? So again, this is a really, really important topic, talking about secondary detection. What about photon counting? Because some people are saying this is the solution, so we then have really, really good CTAs. Well, I think most hospitals don't have photon counting CTs. Those that have photon counting CTs don't have them in the emergency room. And still, the post-processing is not yet at the level that we want for stroke treatment. So in the end, most of us are actually working with such images, right? This is not a photon counting CT, but you can see that the quality of the CTA is not the best. And in the end, yeah, be my guest and try to find the M3 occlusion in those scans. That's not possible without perfusion. So first thing, MIVO detector, this is perfusion for us. What about prognostic value of perfusion? So we all know that the distal trial and the SCAPE MIVO trials were neutral. This was the primary result. If you try and analyze the results with more sophisticated indexes, you end up with such curves. And I will leave the analysis of those to smarter people than me, like Greg and Pierre. We are trying to digest the results right now and understand what the curves are showing to us and how we can leverage that in the future. One thing that I definitely understand as a plumber is that if we take this group of people with a Tmax 6 of over 34, which was the median in the distal trial, and if you take the NHSS of over 6, so actually what we try to do now in clinical practice, then you're having a difference in clinical outcomes of around 7%. And of course, that's lower than what we calculated for in the distal trial with 20%. But still, I think if we have a large patient population with such a group, we can then show that thrombectomy is actually useful for MIVO patients and DVO patients, right? So again, this is something to consider for selecting our patients. What about using perfusion as a biomarker, right? So when we were preparing the distal trial, I was thinking as a neuroradiologist that, you know, maybe the clinical outcome won't be different because the MRS is a crude score, etc. We all know these discussions. And how about we try to use an imaging biomarker, right? We know this from the stent and from the carotid stenosis trials that you can actually take images and use them as an endpoint, right? So what we designed was this delta for distal occlusions. So you take the initial Tmax6, you take the final infarct core on a FLAIR image, and then you measure and you have the difference, and then you analyze this in your population, right? What we saw is that if you have this biomarker, you actually see some difference on the absolute differences of the numbers regarding more brain saved with thrombectomy, even in the distal trial, even with the limitations we are discussing about patient selection, about devices, etc. So even in the distal trial, you see a difference. And if we just stick to the perfect results, so over 80% of saved brain in an individual, these were around 200 people, so it's not a small group we are analyzing here, then you actually see that the trial can be positive, right? So if we stick to this biomarker in the future, maybe also with better technical and devices, we can then show that this is useful for our MDVO patients, right? So keep that in mind. My last point would be, also Pierre discussed about this, you know, French people, the doctors being slow. Everybody is slow. I keep saying this, I think, since I was a resident 10 years now. We are slow, and if you check even on Escape MIVO, and you know that the Escape group used to be the fastest in the LVO trials, they have really, really bad imaging to groin or DOT to groin times. So one way to fix this is go directly to the angio, right? And maybe it's even more important for MDVO patients, as you can see here in this analysis of the Escape MIVO trial, showing that they see in the early window there is a modification of the treatment effect by time. So again, this is not proven yet, but this could be also something that shows us we have to be even faster with MDVOs. How do we become faster? We've discussing this a lot of years now, doing this one-stop management where you go directly to the angio, you do CT, CTA, and CT perfusion now in the angio, right? So even for your mothership patients, you don't only have to do this for your drip and ships, you can also do this for your mothership patients. We do this in Basel right now. You do the whole imaging in your scanner, in your angio suite. You can do this with the Siemens machine, and then you can analyze it with Rapid, and you gain time. So again, this was the first patient published from our group then back in Göttingen. You can see the images. Back then we only had CT and CTA. We published a lot about this, and we've shown that you save time. And now we have the AngioFlow product by Rapid, and this can analyze also the perfusion scans. So you have perfusion with your angio machine. Yes, probably haven't heard about this before, but this is really, really important. Why? Because then you can have your direct to angio cases also with perfusion, and you can also, after the thrombectomy, do a perfusion, have the result, and decide if you're going to give some additional medication, right, to this patient. Let's check one example here of this one-stop case. So the patient arrived in the hospital in the afternoon, and after 10 minutes, we had every image we wanted, and we were able to make decisions in this case, right? So you can see here, this is the native CT. It's not the best of qualities. We know that it's enough to exclude a hemorrhage, right? And we're going to prove this with our spinners trial. but still, this was the initial CT. The CTA was kind of truncated in the upper parts, so I was not sure, is that maybe a distal M1 occlusion, M2 occlusion there? You also acquire your perfusion image, and we've talked about the different cards that you have to check, right? Not only the first summary card, but if you also want to see this, you actually see there is an M2 occlusion there, and then you can go on and decide that, you can go on and do the thrombectomy. You see here the occlusion actually also on the DSA, which is confirmed. And again, this is a useful tool for patient selection and also for making treatment decisions. Even better example here, older patient, higher in HSS, late window, goes directly to the angio. You can see here the initial CT. Again, we can exclude a big hemorrhage here. So we go on and do our CTA. And then here it becomes really, really interesting, right? So is there an occlusion there? I was not so sure, right? There is something there. It looks like maybe a small aneurysm of the MCA. So yeah, even on the DSA, I'm not sure. I mean, I don't know. Would you go on and navigate in this vessel? You can have a 3D if you want from me. Still, it looks like a small aneurysm. Our fellow was not sure that we should go on and try to do anything near there. So, I could make this question like, okay, what do we do? Is it an aneurysm? We just give TPA. We go on and aspirate. We use a microwire near this maybe aneurysm. But again, we had the information up front from perfusion. You can see there is a deficit there. So I was sure this is a M2 occlusion actually. And then, of course, this image looks really, really scary if you just take a look at the image, right? But still, I had the information from the perfusion. I knew there was an occlusion there, which was really at the origin of the vessel. So you go and navigate there, you make your thrombectomy maneuver, and then the vessel is open, and you magically here, also on the AP view, can show that there is actually a vessel there and no aneurysm, right? So I think this is a really interesting case, showcasing why perfusion in every case for us is important. And if I have the time, I would like to show you now one case that I think is the first time worldwide that somebody shows this for a flat panel perfusion. So in this case, we had actually a bleeding, right? And again, a big bleeding, you will see it on FTCT. And usually people, what do? Maybe a CTA. Okay, I will show you the CTA images. You won't see anything there. There is no spot sign. There is nothing in the bleeding that will show you that, you might have to do something fast. And I think this is something that we have to discuss more. We do perfusion in those cases. What do we see? So Greg also talked about these cards and how important they are. You see that the brain around the bleeding is still viable. So this is one important information, I think. The other and even more important information for us is you can take the perfusion scans and you can actually have a time-resolved CTA out of them. And then what you see here is actually a live bleeding during the perfusion scan. So I was mind blown when I first saw this because, again, usually when you see this in the body, you go on and treat this, right? In the brain, we haven't really done this. I know that most surgeons maybe still wait for a couple of hours, but why wait? I mean, you see this, you see that there is viable brain around this with your perfusion scans analyzed by Rapid and delivered to the angio within seconds. So what we did in this case is that we did an angio. Here, again, you can see the extravasation, the active bleeding here. And then we treated this patient with intraarterial andexanet. And after some minutes, the bleeding had stopped. Again, this is just a first case showcasing this. I'm not saying we have to do this in every patient, but it's important to know that we have the tools showing this important information upfront with CT perfusion and with Rapid. So to summarize, I think perfusion is crucial for MDVO detection. We have discussed about this for a lot of years, and this is one of the reasons why we were seeing so many more distal occlusions in Basel compared to other centers. The use of perfusion parameters is going to be important for patient selection. It is right now, and I think in the future it's going to be even more important for the future trials. I think we should discuss about using perfusion as a biomarker for future MDVO trials. And as always, we have to get faster, and AngioFlow is really helping us to have better treatment decisions in those cases. Thank you.
Thank you so much, Dr. Sakojos. Amazing presentation, provocative cases. Love to be able to be the first ones to see a case that it's quite unique with the bleeding happening as you're scanning the patient. Fantastic. So we have a few questions that have come in. I'm going to start with you, Mario. So we're going to work our way backwards here, given that you just mentioned at the very end here something about, the next clinical trial. So what clinical and imaging criteria will you recommend for the next MeVO trial?
Yeah, personally, my opinion is that we were very, very optimistic, right? Going back to the LVO trials and having such a low number needed to treat, we thought that it's going to be the same thing for MeVOs and for DVOs, and that if we treat every patient that comes in the hospital, it's going to be a positive trial. And obviously, this was not the case. So going back to the drawing board, I think we need to have perfusion as an inclusion criteria in those future trials. And I'm not sure what the final criterion is going to be, but I think something around the 30 to 40-ish ballpark is going to be what we need.
Fantastic. Thank you. Thank you. And I'm going to move now to Pierre. How do you use collateral assessment to determine which patients should or should not be transferred to a comprehensive stroke center? I know you covered some of that already, but can you give us a summary here?
Yes, that's a very important but difficult question. I don't think that we should use perfusion imaging alone to decide whether or not we should decide to transfer patient for thrombectomy. Of course, I think perfusion clearly helps. The HIR is one element that can help to take the decision. Typically, a patient with a very high HIR, for which we suspect that there will be a fast infarct growth during the next hours, is not. We have a poor prognosis, but typically, if the patient is admitted early in the primary center, is young, has very healthy, no former hand disability, I think there is no question about we should transfer the patient. But typically, if we have an older patient with some disability and very high HIR, it's one element that could help to decide whether or not we should transfer this patient for EVT. So not use this as the only element that will decide whether you should treat the patient, but as one tool to among other clinical elements.
Right. So multiple factors affecting that decision. It's really not just about the imaging, but you have to look at the patient as a whole, the whole situation, right?
Exactly.
Great. Is there a specific time point, the time window at which you say, well, you know what, even though those collaterals may be great, we've got a good HIR, the patient is too far to really make that transfer. Is there a point, is there a threshold, a time threshold that challenges that decision or the utility of the HIR?
I don't think so. It's worked in a broad range of patients, regardless of the time window. Typically the patient with poor collateral will have core growth in the coming hours. So even if you are in the late time window, the patient with poor collaterals will have faster growth in the next few hours. So I think this tool can really be used regardless of the time window where the patient is admitted in a primary stroke center.
And one more question for you that has come in. Is there an age relationship here with collaterals? In other words, are younger patients, do they have better collaterals than older patients, vice versa, or is that independent of age?
Yeah, that's an interesting question. In fact, it's when you look at the literature, there are different results. So there is not a consistent relationship between older age and poor collaterals. So I'm not sure that there is a strong relationship between collaterals and age. That's my feeling, because we have some positive studies and others that do not show any relationship. So obviously there's no strong relationship with age.
Great. Thank you so much. And now we have a question for Dr. Albers. Guidelines typically recommend perfusion imaging for the late window patients. What's the rationale for obtaining perfusion imaging in the early window patients?
That's a great question, and I saw in the Q&A there was a complimentary question. Somebody said, that first patient you presented, is that somebody you would not do an EVT on? And the answer is, we have been doing perfusion imaging for 25 years at Stanford, and we had already identified years ago that if you come in and you have horrible collaterals, that those patients never did well with EVT, even ones who'd come in a relatively early window. But the guidelines have said you don't need perfusion till late window. And I think it's because it's a relatively small percentage of patients who have these really horrible collaterals early. But what we've seen is that they don't do well. So right now we have a study called Outer Limits, which will be starting in the US shortly, and it's already approved in France as well, to be looking at some of these patients, particularly the large core patients, to show what is the outer limit. Right? There are patients, like I showed you, that I think do not benefit from thrombectomy, but we need more clarity on who those are. So we have seen studies that have shown even in early window, patients who have no mismatch don't benefit from thrombectomy, but we need more data to clarify this. The other thing is that patients need to be diagnosed properly as to who's having a stroke and who's not. And what we didn't have time to talk about today were stroke mimics and stroke chameleons. So if somebody comes in, whether it's early window or late window, it's not always clear who's having a stroke and who's not. So the perfusion imaging is very helpful for differentiating who's having a stroke versus a stroke mimic, or who has atypical symptoms and actually is having a stroke and is eligible for acute stroke therapy.
Wonderful. Well, thank you so much. This went by so quickly. We learned so much today, but we're already at the full hour here. So before we wrap up, I just want to thank all our speakers for sharing your expertise today, and thank you for your time and engagement. I appreciate the audience sending in some questions. We covered a lot of ground today, and we know that you may have specific questions about these insights and how they apply to your institution, your organization. Maybe we didn't get to cover them all today. So if you'd like to take a deeper dive or request additional information, please visit our dedicated follow-up page. It's being posted here on the chat, so you're able to send some questions in. We will share them with our speakers, and we will provide you the answers. Please feel free to take a look at that. As a reminder, you will receive an email with today's recording. And so on behalf of the entire RapidAI team and all our speakers, thank you for joining us, and have a great rest of your day. Thank you so much.